Sorry about that, Chairman. We should be good. We are live on YouTube and we are recording it, and I believe KET is also piping out the feed on their end. Thank you.
All right, thank you very much. Appreciate everyone's patience and indulgence while we try to get this rolling in this world that we live in. And I know we took a preliminary roll call, but let's do it again since I know some people have come on and possibly may have lost.
Yes, sir. Senator Alvarado. Senator Danny Carroll.
Here.
Senator Jimmy Higdon. Senator Morgan McGarvey. Representative Gooch. Representative Gibbons-Prunty. Representative Steve Sheldon.
Here from home.
Thank you. Representative Wilner.
Here from home.
Senator Meredith.
Here from home.
Representative Elliott.
This is Representative Prunty. I was muted. I'm here from home.
Wonderful. Thank you.
Mrs. Alvarado, I'm here from home as well.
Wonderful. Representative Elliott.
I'm here remotely.
Wonderful. We have a quorum.
All right, thank you. Just a couple of housekeeping items. Just remind everyone that please have your mic muted unless you're speaking actively to the group. And we ask you to use the chat function if you have a question so that we can get you in a queue and make sure everyone has an opportunity to get the information that they need. We do have approval of minutes from our last meeting that were distributed. If everyone's had a chance to look at those, is there a motion to approve those?
I make a motion.
Motion by Alvarado. Is there a second?
I second.
I believe that was Representative Elliott. All those
Yes,
in favor
sir,
of the motion
that's
vote aye. All those in favor of the motion vote aye.
Aye.
Any opposition? Any opposition by like sign? Then minutes are approved. First item on our agenda is an update on the Legend Drug Repository Program. And Mr. Hadley and Mr. Gray, again, thank you for your patience and indulgence while we get through these meetings. And this is a new learning experience from all of us. And hopefully we can do a much better job next time, but we appreciate you being here. It's been a year since you've been with us. And we thought we had some excellent discussion last year about this program. But as we're putting the agenda together, apparently we've run into some obstacles. It was my understanding when we finished our meeting last year that the Kentucky Board of Pharmacy to get this program underway. And just a reminder to the committee members, there are other states who have adopted this program, have realized significant savings in terms of millions of dollars for a Medicaid program. So that is our interest. But we had not had any communication since last year, and no fault of anyone, just time flies. But when we reached out to Mr. Hadley about this program, he shared with us that there were some concerns and problems. So we asked him to come back to the committee and talk about those and what we can do to possibly move this thing forward. Because, again, this day and time when we have so many demands for dollars from our budget, that any place we can look to save some money or generate new revenues, we want to do that. So, Mr. Hadley, if you would, please, the floor is yours.
Okay. Thank you. Thank you, Mr. Chairman, for allowing me to appear again. And just a quick summary of what has transpired since we last met. And when I left that meeting, I was very enthused about the idea of providing repository drugs for Medicaid patients because it solves multiple problems. Number one is drug disposal, but also it saves money for the Medicaid programs. So General Counsel Auntie Gray and I met with Jess and Joseph and Jonathan Scott of the Medicaid program about 10 days following our meeting, and just to discuss ways that we could use the Medicaid program to allow us to create this entity. And we didn't find an answer that day, and we gave it a lot of thought and conversation and really didn't come up with a way forward that day. I followed up with both gentlemen, maybe a month later, no progress. So I went to other states to see what they were doing. I talked to John Rossman. He's CEO of SafeNet RX, which is the Iowa repository drug program. And it is under the Iowa Department of Health, and it is a 501c3 corporation, and it receives appropriations from the state of Iowa to the tune of $600,000 a year was the most recent number that Mr. Rossman gave me. And so I asked him when we were talking if he used Medicaid, if he was able to supply drugs for Medicaid patients, and he said he did not because of regulatory issues. And then he suggested a partnership with Iowa and Kentucky. And I didn't pursue that idea because of the magnitude of the appropriation that they were receiving. And so then I went back to the Regulation Committee, Board of Pharmacy, and told them about the potential of the Iowa partnership. And their direction to me was to let's get some guidance from the full board. And they also suggested I talk to the folks at Faith Community Pharmacy in Florence, which I did. And that was a fortuitous conversation because it put me in touch with George Wang of a company called Serum.org, which is based in Palo Alto, California. And it is a repository drug company, and they have operations in 6 Western states. And he was also good enough voluntarily to write a draft regulation based on Kentucky repository drug statutes. At that meeting, that last time we met, I committed to a Medicaid viable repository drug program, and quite frankly, I was not able to find a way to do it. And hopefully, my friends from Medicaid, we've talked several times since then, and I think they have some insight or some ideas that may be able to help us. And we have in your packet, you have a copy of the repository statute, and then there are 3 different draft regulations. One is from Sullivan University College of Pharmacy. One is based on the Iowa statute and regulations. And the last one is the one I mentioned from George Wang based on the Kentucky statute. And General Counsel Anthony Gray can, the one that we prefer is the Iowa version. And Anthony can walk you through that if you would like to just get some of the highlights from that proposed regulation.
Well, certainly. A question that I had for you, very basic, is do you think this program has promise as we originally anticipated?
I think it has a lot of promise. The problem remains is finding the way forward within Medicaid. And I think, again, the folks from Medicaid, I think, can have some insight that they didn't have last time we spoke. And I don't know that they have a full solution. I don't want to speak for them, but I think they have some additional ideas that may be viable.
All right. Well, with that, Mr. Gray, please feel free to proceed.
Thank you. Good afternoon. If you look in your packets that we provided, there, as Director Hadley said, there are 3 different models. We modified the Iowa model because we felt like that one mirrored our laws more closely than any of the others, except for the issues that Director Hadley had raised. I mean, I won't go through the entire regulation. As you can see, it's quite thorough. It's about 8 pages. Basically, we modified the definition to fit with Kentucky, our KRS language of what the different entities for contractor and repository and all of those are. We basically just shortened some of the standards and qualifications. We took out some restraints. For example, I think Iowa had that, you have to have a valid driver's license to be able to participate. And we took some of those out. We did leave the age restrictions in. Obviously, this is not applicable to any controlled substances. We kept a lot of the protection measures in for the drugs themselves. For example, storage requirements, what drugs can be accepted and when they can be accepted by. Inventory requirements, we kept those. We also wanted to make sure that the standards for inspecting the donating drugs were still included. That is also listed in our regulation. Wanted to make sure that the drug supplies are in fact secure and stored securely. That was something that was very important to us. We kept that as well. We delineated standards for donating the drugs and supplies. They have to be prescribed by a healthcare practitioner to be eligible to be part of this program. We also put in language to prioritize the dispensing of these drugs to individuals. First to indigent, then to individuals who have no active third-party prescription drug reimbursement coverage. And then third to any other individual who is an indigent or uninsured individual. So we kept that information in. We have record-keeping requirements. Again, I talked about the eligibility to participate in this program. You have to be a Kentucky resident and have no reasonable financial means to pay for the prescribed drug. Also attached to the Iowa model are forms, 3 forms that we would incorporate into our program if it is, it is in fact adopted. And I've attached those. One is the Drug Donation Repository Program Notice of Participation form. That is what the facility would fill out that would be participating in the repository program. The Board of Pharmacy obviously would need that so we could have records. We would also have a program for the participant. We have to sign up to participate in the program to receive the drugs, and the individual donation. Those are basically the nuts and bolts of what we have here. The only thing that we would need to add would be the input for if there would be any language that would need to be included in regards to Medicaid. Thank you.
Well, this takes a little bit different turn than I remember from last year. It seems like you all have a heavier focus on those who are truly charity indigent and by default should be eligible for Medicaid. What's been your conversations with the Department of Medicaid Services?
Again, we've talked several times, and Dr. Joseph has talked to some of his contacts around the country and to get their ideas. I don't think he's found anybody who has it fully implemented. Medicaid is on the call if you would like for them to participate.
Yeah, most certainly. I hate to kiss anyone just off the cuff, but if Medicaid can talk about this, I would appreciate that.
Hello, this is Lisa
Is
Lee.
anyone from?
Can you hear me? Hi, can you hear me now?
Yes, I can.
Hi,
Yes.
I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services. We have discussed this internally. What we have also done is I personally have reached out to some of my colleagues in other states to get information. I haven't heard anything back yet. Some of our concerns related to this, IT costs, how would we build this into the system to track those drugs that had been donated and subsequently been given to Medicaid members? A little bit of administrative burden maybe on the providers who accept those drugs and how they track them and store them. Specifically have looked at the prescription drug repository program in North Dakota. They have some pretty good information on the drugs, how they are donated, how they are dispensed. They do have certain criteria, of course. It is a volunteer program, and they do pay a fee of $11.50 to cover the cost the participants who receive the drugs. If they are uninsured, have to pay an $11.50, assuming sort of like a dispensing fee for those drugs. So definitely, I think a little bit more research we need to do to find a Medicaid program somewhere that has implemented this already, see if we can learn from them, what worked, what didn't work. But thus far, we haven't been able to find a Medicaid agency that has come forth with actual information on the benefits of this to the Medicaid program. But more than happy to continue to explore and research.
Well, I think the benefit's very simplistic. You know, if you got a patient who's on insulin and passes away, never used it, and the family wants to return it to the local drugstore for some type of credit or something that could then be donated to the Medicaid program to repurpose for that reason, I would think that'd be a significant savings for everyone involved, would it not?
It certainly seems that way. And again, we'd be more than happy to work with the Board of Pharmacy as we move forward to kind of make sure how we build that into the Medicaid program. I'm not sure. The donation, I would think, would go to a pharmacist in the state, and then the Medicaid member would have to go to that pharmacy to get that medication. It is a volunteer program. The program in North Dakota, for example, has to maintain records of who donates that medication. They have to have those records on file for a certain amount of time. So I'm not sure how we would, if a Medicaid member went to the pharmacy, how do we identify that that medication was actually one that was donated versus one that the pharmacy already had on stock? Those are some things that would definitely have to be worked out and explored.
Well, I appreciate that, but I do know other states have had success with this. And again, that's not a tremendous money saver, but every dollar should count for us this day and time, particularly as we're coming out of this COVID-19 crisis. You know, this legislation passed in 2005 and has never moved forward. And I think we've left millions of dollars on the table as a result of that. I think it's a possible small revenue stream for local pharmacists. You know, I like the idea of people bringing their donated drugs to the local pharmacist. That helps everybody in terms of transportation and not creating additional bureaucracy. So maybe I don't see the hurdles as substantial as other folks do, but I think this program has promise, just like we did last year. If there's some regulations that we need to pass, so we can certainly do that during the 2021 session, but I really would like to see us move forward on that. But I'm sure we've got other committee members who want to speak to this. Representative Prunty, I think you have a question.
Are y'all still there?
Prunty?
Yes, I'm here. Sorry, I couldn't get
Yes.
back to my meeting from the text. I just want to commend the work of Mr. Hadley and Mr. Gray and appreciate the work of the Board of Pharmacy. And I just want to share a personal experience. My mother had ulcerative colitis, and when Humira quit working and they tried to, she ended up having surgery, they couldn't give $7,000 worth of Humira away. And the pharmacy, local pharmacy couldn't take it back. And I just think it's a shame. And I think I would really encourage working out something to save money and to just the waste. My mama taught me not to waste. So I just think we need to keep looking at this program. I think it's very important.
Representative Sheldon, I believe you have a question.
Yes, sir. Chairman Meredith, can you hear me all right?
Yes, I can.
Okay. First of all, thanks for Mr. Hadley and Commissioner Lee and appreciate all the work you guys have done to try to put this in place. These programs in the last, number of years, there's 30, 35 states that have them, but there's a whole lot of these programs that never get implemented. And there are some barriers to get over. However, I think North Dakota certainly is on to something. I've had an opportunity to discuss this with Mr. Hadley as well as Dr. Jessen. And the key is that, pharmacies in most of these states they're trying to do all this through charitable type work, where pharmacies are donating their time and effort. Charity clinics are donating. The Cabinet of Health and Family Services, in this case, maybe not be getting a appropriation to be able to run a program like this. So there are some barriers, but the way you're going about it now, and I think the way Representative, or at least Senator Meredith last year was anticipating, and I think we all was trying to work out something with Medicaid that allowed us to work out what sounds very similar to North Dakota. You mentioned that, where pharmacies are more than happy to jump on board and take these medicines back and then just simply be paid a dispensing fee to redispense that. To be able to track those drugs would be just like we do in a 340B program. We would put identifiers on those drugs. It'd just be a different identifier. So that's a matter of a simple entry that would then go back to Medicaid. So nothing simple, but there is a way to do this. We can get a lot of fun. And one more thing, the reason most of these things don't work is because there's a lack of awareness through public awareness of the program. So I would encourage you that if we do this, that we find some way to get the word out, because people will. Now, I'll finish my comments with I did some quick numbers. I have access to about 50,000 prescriptions a month that were being filled in Kentucky, and that's only 5 stores. But I just went through those stores and I picked the 5 things that Medicaid was paying me for the last 12 months. Just 5 things. 2 or 3 of them were insulin products. The other 2 were inhaler products, which are typical products that are being returned. Of those 5, you paid your cost. What you actually paid for those medications was $516,000 in 12 months. That's what you paid for those 5, just those 5. So what would happen if you paid, let's say, and I think that represented about 150 dispensing fees. So if you paid the $10 or $11, you'd be out 150 times $10 versus 550,000. I know those numbers are real. I'm not, these are real numbers. So if we find, of course, we're not going to get all that back, and we got to figure. But I'm like Representative Prunty. She mentioned that people will come by and they'll say, "Gosh, I've got these specialty cancer drugs or specialty inhalers and boxes of insulin, just mounds and mounds of bags of insulin." And if we had an opportunity to do that, so there's 2 or 3 ways you can go with this, but having a central agency like the Cabinet of Health and Family Services, putting identifiers on there, and then reimbursing your pharmacies for their trouble to dispense a drug that's not going to cost you a dime. I think that there's real promise here, and I've talked to Dr. Jessen and I know Joseph Jessen. I'm sorry about that. Jessen Joseph. Yeah, I'm gonna get it all mixed up. But anyway, we talked, and I feel like there's a way forward, and I appreciate the work you've done so far, and look forward to hearing back from you. Thank you very much.
Commissioner Lee and Mr. Hadley, Mr. Gray, what is our path forward for this?
I think we've got the mechanics laid out in the regulation. And as Anthony said, the only thing we lack is the Medicaid mechanism that we can utilize those drugs.
Hi, this is Lisa again.
Commissioner Lee.
Yes, and I appreciate the numbers. I agree that there could be some cost savings. I think that the one thing that we definitely need to look at is the administrative cost. Will they be offset by any savings? How much is it going to cost to design our system? And look at those kinds of things to make sure that the juice is worth the squeeze in this case. Make sure that we're going to reap benefits. We may have to spend some money up front to get this started. And then how long is it going to take us to get a return on our investment? So there will be some administrative costs, and I think that that's what we definitely need to look at and explore. But definitely Medicaid is not opposed to anything that's going to be a cost savings measure. More than happy to see what we need to do with the system, how it all works, and what sort of administration is involved. Are we going to have to hire someone to assist oversight, those sorts of things? But more than happy to continue to work with the Board of Pharmacy as we move forward.
I think Senator Danny Carroll has a question. Senator Carroll?
Yeah, thank you, Mr. Chairman. The question is, have we looked at, or would it even be possible to use our public health departments as a distribution point for these medications as they are utilized for other health type services? Is that a possibility, and has it been considered?
That's a great idea, and I'm not sure if it's been considered, because it would be to use the public health departments would be really smart, because if we started a program like this, I don't think that it would be specific to just Medicaid members. There would be individuals who are not enrolled in Medicaid who could also access those services. So I guess, that's part of the administration too. Is it housed in Medicaid and the Board of Pharmacy, or how is this housed? I think that suggestion of looking at the local health departments may be worthwhile to get the broader audience. Because again, it wouldn't be strictly related to Medicaid members who would receive those medications that were donated.
Thank you, Commissioner.
Commissioner Lee, at least my assessment is it looks like the ball's back in your court. I'm assuming that you will pursue this. What type of timetable are we looking at?
Right now I have.
And what can we do to help?
I don't know what sort of timetable I'm looking at. I'll have to regroup with Dr. Justin Joseph and my team to see what we're looking at, what we have to do, what all tasks are involved, and get back with you with some sort of a timeline.
Well, not to back you in a corner, but when could we expect to hear from you regarding this?
Regarding a timeline, I'll get with my staff just as soon as I can, first of next week, and see if I can.
And I don't need a firm date. I just need a general timetable.
General timetable. I'll get back with you regarding what we found. Couple weeks, 2-3 weeks. No later than a month from today.
Okay, so our next Oversight Committee meeting, we have a follow-up report?
Yes, we will.
Is that fair? All right, thank you. I appreciate it very much. Any other committee members have questions or comments for Commissioner Lee or for Mr. Hadley or Mr. Gray? If not, I appreciate all of you being here today and your willingness to take on this project. I think it does have some very positive implications for our Medicaid program, but also the recipients, and that's who we're all here for. So thank you for your time today, and we look forward to progress on this and hearing back from you.
Thank you.
Unfortunately, Commissioner Lee, I guess you don't get to leave because you're next on our agenda. But again, Mr. Hadley, Mr. Gray, thank you very much for participating today, and I appreciate, again, your patience as we had to delay this just a little while. But thank you for being here, and we look forward to working with you.
Thank you. Thank you.
Commissioner Lee, our next item is effects of COVID-19 on Medicaid enrollment and expenditures.
Yes, I think I watched a little bit of the Health and Welfare Committee meeting a little while ago, and as we know, COVID-19 is something very new. As we move forward, when the state of emergency was declared, the department began implementing flexibility. Our goal at the beginning of this was to make sure we could get money to providers, make sure that providers were not overburdened, make sure that individuals could have access to care in the event that they were diagnosed with COVID. So one of our first steps included developing an 1135 waiver for the Center for Medicare and Medicaid Services that was subsequently approved. Under that waiver, we have the flexibility to suspend prior authorizations with the exception of some pharmaceutical drugs. We can also temporarily enroll providers if they are currently enrolled with Medicare or if they have been screened and enrolled with another state Medicaid agency. We thought that was important in order to bring a broader base of individuals and providers into the state in the event that our healthcare system became overwhelmed. We also were approved to allow care in alternate settings in the event that we had to move individuals from one facility to another, for example. And also, as far as providers, we knew that the hospitals and the long-term care facilities were starting to get an influx of patients. So for hospitals, we allowed an administrative day for them to start billing administrative days. Now, what this means is if an individual is in a hospital and they have been treated and they no longer meet acute level of care and cannot stay in that hospital because they wouldn't receive payment from Medicaid, we're allowing them to keep those patients and paying them an administrative day that allows them to keep those patients so that they don't have to transfer them, for example, back to a long-term care facility. They're allowed to keep those patients until they become more stable and can move out. We also gave the hospitals a 20% increase in their DRG rate for COVID positive patients. And we typically have a dish payment that we give to them in payment with 10% being in September. We have given that payment to them early. We gave them that payment in May in order to get some funds to the hospital. Long-term care facilities, we have authorized a $270 per bed per day add-on for any COVID positive patients that they treat. We have also we've streamlined our eligibility process for long-term care. For example, long-term care patients or Medicaid applications are really quite complex because they involve the assessment of assets and annuities and those sorts of things. So we have streamlined that process in the interim to allow for self-attestation so that those patients could be determined eligible in a quicker manner in order to get funds to the long-term care providers. We've also been providing testing, the cabinet has been providing testing for patients and residents, patients and employees of long-term care facilities. And in addition, we have increased the bed hold days for Medicaid patients from 14 to 30. So what this means is if a patient has to leave the long-term care facility in order to go to a hospital, Medicaid's previous policy allowed us to pay them for 14 days to hold that bed for the Medicaid patient to come back into. We've increased that to 30 days. So now we will pay them 30 days to hold that bed for a Medicaid patient. We have also offered to place accounts receivable on hold to providers if they request a financial hardship. To date, we've had 14 providers submit affidavits saying that they requested assistance, so we have placed their accounts receivable on hold. We've waived cost sharing, and we have also implemented, we've always had presumptive eligibility. Presumptive eligibility is a Medicaid eligibility program that is time limited. Currently, hospitals can grant presumptive eligibility to individuals who are in the hospital but do not have insurance. They can grant temporary Medicaid eligibility so the provider receives payment and the individual can receive treatment until they complete a full application. So during the COVID emergency, we have requested that the state cabinet for Health and Family Services be allowed to be a qualified entity to grant presumptive eligibility. So we are allowing individuals to come into the program temporarily. Again, this allows providers to receive payment for treatment, and it allows individuals to get treated. So it's temporary eligibility, but we have that in place to enroll individuals. So along those lines, the other thing that we did, of course, I think a lot of individuals have been talking about telehealth. We have encouraged the use of telehealth so that our providers can continue to receive payments. We have released some guidance on well child checks. We did allow and are allowing providers to deliver well child exams via telehealth, but we have been looking at our data, and this has resulted in a decrease in immunizations. So we're now having conversations. Kentucky Medicaid is involved in a national work group specifically devoted to increasing those immunizations, making sure those children can get those immunizations before they go back to school, because the last thing we want is a measles outbreak or something like that once we get our children back in school. We've also allowed case managers in our home and community-based waivers to deliver telehealth services to our members in our homes. And we're also allowing licensed behavioral health providers to deliver services via telehealth, with the exception of residential substance abuse disorder treatment and residential crisis services. We have been monitoring our expenditures related to telehealth in our fee-for-service population, which includes our long-term care population and our home and community-based population. We have seen an increase, for example, in January of 2020, those providers in our fee-for-service population billed $13,649 in telehealth services. In May, which is the latest complete set of data, we saw that 13,000 jump to 3.9 million. So definitely a lot of expenditures in the telehealth world. Managed care organizations in January 2020, we've noticed that there was a $378,000 billed in January of 2020 for telehealth. In May of 2020, the managed care organizations report $19 million in the delivery of telehealth services. So as far as budgetary impacts, the additional 20% add-on for the DRG in the hospital, we've only noticed about a $483,000 payment for hospitals related to that 20% add-on. But we believe a lot of that is due to some system changes delaying that implementation, and that's since May 15th only. We've seen $483,000. One thing that we're definitely keeping an eye on is the deactivation of prior authorizations. So prior to COVID, we had certain services that would require prior authorization. And we've noticed that prior to COVID, we had those plans that required prior authorization. We had about 5,000 per month that came through the system. Beginning in May, we started noticing about 10,000 of those claims coming through that that required prior authorization, but because we relaxed it, they didn't have to have it. We have seen an increase in one particular revenue code, which is for semi-private room and board. Prior to the emergency, those revenue codes were being billed around $150,000 per month is what Medicaid was paying out. Since the emergency, our initial analysis shows that went from $150,000 per month to $6 million. So this is a little bit of a concern with the prior authorizations. We want to look into those. We have had a discussion with our managed care organizations, and we'll be allowing them to reinstitute prior authorizations beginning August 1st, with the exception of behavioral health and substance use disorder treatment services. So they will give a notice to the providers. We are allowing them to implement those prior authorizations again. Again, with COVID, everything is fluid. We're monitoring the situation. We know that at any time, if the healthcare system becomes overwhelmed, we may have to look at those prior authorizations, and we may have to pull those back at some point. We have also increased our non-emergency medical transportation costs by $700,000. As far as Medicaid enrollment, we have since March the 2nd, of 2020, we have increased our Medicaid enrollment by 164,274 individuals. Now, 77,000 of those are enrolled in our presumptive eligibility. And the reason that we have that many in presumptive eligibility is individuals who are enrolled in Medicaid and traditional Medicaid are assigned to a managed care organization unless they are in a long-term care facility or they're in a home and community. So we started enrolling those presumptive eligibility individuals in our fee-for-service program in order to offset costs that would be associated with capitation payments to managed care organizations. So those individuals in the PE program, which is a presumptive eligibility, are enrolled in fee-for-service. And then I think one thing that I would like to say also, I'd like to talk about is the 6.2% increase in FMAP. I know there's been some questions as to why the Department for Medicaid Services didn't just automatically give all providers an increase in their reimbursement rate of 6.2%. But that 6.2% was basically, it's an effective means of providing fiscal relief for state Medicaid agencies because of increased enrollment, because of expenditures related to COVID treatment and testing. And we believe that 6.2, we have given, for example, the long-term care providers in the hospital some increased payments, but we believe that the bigger bulk of that 6.2% increase will be used to offset the state share costs associated with COVID-19 and the increase in expenditures and increase in enrollment. And in addition, that 6.2% has certain criteria attached to it. Kentucky does meet all of that criteria right now. For example, we have to maintain eligibility standards, not charge premiums, and cover any costs associated with COVID. So that's one of the reasons that the 6.2%, we didn't give an across-the-board rate because we didn't think it would be prudent. We don't know what our budget is going to be like in 2021. We do know that in 2020, we will be fine. We'll be able to meet our budget, but there's so many unknowns for 2021 right now that we're just not sure what that is going to look like. We continue to monitor our budget and the expenditures related to COVID. And then I think we've heard some talk too about the increase of telehealth and how useful it is. So one thing that we're also doing is we're looking at when we emerge from this emergency, what are some of the flexibilities that we have in place that we would like to maintain? How can we build a better healthcare system? How can we better deliver care after the state of emergency? So with that, I think I'll stop and see if there are any questions related to the COVID impact.
Well, thank you. You've thrown a lot of numbers at us, but I appreciate your very proactive approach to this. It looks like you did a lot of work in anticipation of what's going to happen with COVID-19, but again, a lot of numbers. I'm trying to summarize this, but again, not put words into your mouth. The increased cost from COVID-19, everything we have talked about, including the expansion of 154,000 additional people, that cost should be covered by the 6.2% that the federal government has allotted to us. Is that fair?
I don't think that it will be covered by the 6.2. I think it will help offset some of the state costs because it will reduce the state share that we have to pay. We are going to have increased costs due to COVID, but the 6.2 will allow us to draw down more federal dollars than we would have absent that 6.2% increase. So it's not
surprised that you said we're okay for 2020.
Yes, 2020, we are fine because the fiscal year ends this month. So we have had some increased costs, but it hasn't been so much that we are going to exceed our budget. But 2021, the budget for fiscal year 2021 is uncertain.
So what we're really saying is we really haven't recognized this cost, but we will in next fiscal year.
Yes.
Is that fair?
Yes, sir, that is fair.
Well, a lot of discussion about the 6.2, and I understand the rationale for your decision, but particularly for the nursing home industry, incurred a lot of expense with PPE. You've had provided some additional funding to nursing homes, but do you have a total on that number? How much additional reimbursement we've given to the long-term care facilities?
I don't have that number right now, but I can get that and get it back to you.
I think it's important that and I'm sure you heard the presentation maybe earlier from the Kentucky Hospital Association about how we now have 20 hospitals that are beyond financially distressed, and that's grown from 12 to 20, as Representative Bentley pointed out to us. But the long-term care industry has had a comparable financial challenge, and I'm not sure that they have fully recouped their costs or can prepare for the next. I would be curious as to how many additional dollars we have given to the long-term care industry just to kind of keep track of this. But with that, I believe Senator Alvarado has a question. I'm sorry.
We do have those numbers. I just don't have them in front of me right now. We are tracking those numbers.
Okay. All right. Senator Alvarado.
Thank you, Senator. Appreciate it. Commissioner, thanks for your presentation. I did have one question that I think I don't know that Senator Wise is a member of the committee. I think he's tuned in watching, but he wanted this question posed. And so I'm going to read his question that he wanted to make sure that we got an answer for. That a lot of the MCOs are paid typically a lump sum as a contract from the state when, I think it's either annually or every other year, but they then use those funds to obviously help to pay off, funds and things for constituents of Kentucky and on issues. For the past 6 weeks, I know there's been a lot of the dental offices have been closed throughout the state. And so very few claims were paid by the MCOs in this regard on the dental side of it. And I guess this question was, where are those funds now? I mean, a lot of dental offices couldn't use telemedicine. People had dental issues and needs. A lot of that was put on, that was put on the backside. I think even their volumes now are not quite where they need to be. And so his question is, where are those funds? Are those going to be touted as profits to the MCOs this past year? Are they parked to be used in the future for a lot of those dental offices? And he had just questions in that regard. Maybe you could address that.
Yes, so the managed care organizations are paid a per member per month capitation payment for the members that they serve. We are watching and looking at the expenditures to see where they go. We know that a lot of providers, not only the dental community, but a lot of providers have reduced foot traffic. The managed care organizations are still spending pretty much the capitation payments. We've seen the big increase in telemedicine. So while it may not be going to the dental community, it is going to other places. And in the event that at the end of the year, this would not be a bonus for them, or it wouldn't be any kind of profit, because all of the managed care organizations are held to a 90% MLR, which means any of their capitation payment that they don't spend on services, and they only have 10% admin. So anything less than 90% of their capitation payment that's not spent on services has to come back to the cabinet.
Just a follow-up, Senator, if I could. So to that end, I mean, and that brings up an interesting point. I know that I've talked to a lot of our EMS guys locally. They have remarked at how much less volume they have, and that a lot of people have been concerned about going to emergency rooms for care because of COVID-19. And so people have had heart attacks and strokes and things at home. And talking to some of our paramedics, at least in my district, have said, they normally have quite a few runs that they say are not necessarily emergency. People just have transportation needs or want to get to the ER. But the runs they're making now they're less, but they're more intense, right? They're people with higher acuity of needs. Have we seen, I guess, with less ER runs, I mean, are we going to see some savings in some of those things? I mean, in terms of that brings up a curiosity to say if we're going to see savings on ambulance runs, on ER visits, because we've seen less volume there, or are we just shifting that cost into other factors?
I think there definitely is some cost shift, and I think that at the end of the year, we can do some analysis. Well, not even at the end of the year as we go forward, because we have been asking the managed care organizations, what are your expenditures? What are you seeing? Because we definitely want to make sure that we have a viable provider network when we emerge from this emergency. And there is some concern, of course, on Medicaid's part that some of our providers may close their doors. We may have some that are already close to retirement, and this may push them into retirement. So we definitely want to keep an eye on where the funds are going, and is it cost shifting, and is it shifting to one area more than the other? What do we need to do? And again, that was one of the things that Medicaid fee-for-service that we put into place was the hardship. If a provider was, we were going to recoup, for example, if they had funds that we were recouping, we allowed them to sign an affidavit, and we have stopped recoupments on any providers who are out in the community who are experiencing a hardship. So we have had communications from dental providers. We've had communications from transportation providers and others stating that they are having difficulty. And we know that. We know that across the board, Medicaid providers are having issues. And I think this lends itself to a broader discussion on what role does Medicaid play in all of this? Are we just a payer of services, or are we going to be a partner in the delivery of health care? And if we're a payer of services right now, so we know that we're going to meet our 2020 budget, but we're going to have bigger, broader discussions about the Medicaid budget and what we can do in times of emergencies like this. We would need to, how could we have funds infused into our program, for example, to give to providers in the event that the cost shifting is happening? If we can identify that and supplement other ways, we could do that, but I think that it does lend itself to a broader discussion on the role of Medicaid in the delivery of healthcare services.
How much do you think the projected shortfall will be for 2021? Do you have a preliminary number? Again, not trying to hold you to anything, but
I do not have a preliminary number, and I think that 2021 hasn't even started yet, and unsure how this pandemic may go.
all right. Representative Prunty, I believe you have a question.
Thank you, Mr. Chairman. I just want to echo, you've already asked my question. I just want to, I had tried to Facebook message my long-term care facility folks that had reached out to me that I emailed you about, Commissioner, and you graciously emailed me back. And I just want to echo, I'd like to follow up on how all of this has impacted them. So just thank you for your work and your presentation.
I have a last question for you, and it may be too broad a discussion for this meeting. We may need to do it in another one, but how do you verify the medical loss ratio?
All of the managed care organizations submit encounter claims to us detailing the services that they have spent. And we look at that compared to we know exactly how much capitation payment we paid them. We look at the amount of capitation versus the amount of medical services. And then we allow a 10% admin. So any difference in that would come back to the cabinet.
Are they required to report recoupment of payments?
Yes, they are.
And how is that verified?
I'd have to double check, but I believe that comes into our system in the form of encounter claims. They would have to, for example, if they paid a claim and then there was a recoupment, they would have to void that claim and reprocess the one with the amount that they have recouped.
Well, I appreciate your action in asking them not to recoup during this period, but I'm hearing from several providers across the state that there has been just tremendous recoupment efforts on the part of the MCOs, but that's something I think we need to talk about for another day, but just want to put that on your radar that we need to have some discussion about that. Are there any questions regarding this particular agenda item before we move on to our last? If not, again, Commissioner Lee, we'd like you to update us on the managed care RFP process.
Okay, if I can, try to share my screen here because I do have a presentation. Can you see my screen?
Yes, ma'am.
Okay. So
I did.
Okay, good. I'll kind of know we're kind of going over on time or getting close to time, so I'll go through this not real quick, but just enough to touch base. So I think first of all, just to give a little level set with Medicaid managed care. Currently, 40 states use a capitated managed care model, and you can see that Kentucky is one of those 35 states that does utilize managed care. You can't see my screen? I was just told you can't see my screen.
No,
Uh,
we did, but now we can't.
Okay, I think I'll just go ahead and go through the presentation. I don't, again, I guess, you know, like you said, Senator Meredith, these are things that we learn as we go forward. National statistics, most states have, you know, 7 managed care organizations on average. Kentucky is below the average with 5. Current, I do have a little bit of a background. I think in order to know how we got to where we are today, it's good to know the background. And I think that this next conversation or the slides depict that Kentucky has been operating in some sort of risk-based managed care since 1997. I think that we can take from these next few comments that I make that Medicaid managed care is constantly evolving. So many of you may have remembered back in 1986, Kentucky operated a primary care case management that was called KINPAC. We moved to a risk-based managed care partnership in 1997. We divided the state up into 8 regions. We had 2 providers or 2 managed care organizations bid on those regions. Regions 3 and 5 were operationalized. Region 3, of course, was known as the Passport region, and 5 was Kentucky Health. Region 5 could not operate. They were not profitable, so they folded, and we were left with 1 managed care region because no one else would bid in the state because particularly Eastern Kentucky was viewed as too unhealthy. Then we went statewide managed care in 2011. Again, we had the 8 regions, but Passport only operated in Region 3. And then in 2013, all MCOs began operating statewide, including Region 3. We currently have 5 MCO contracts with Aetna, Anthem, Humana, Passport, and WellCare. The original contract expired on June 30, 2020. We have extended that contract until December 31st of 2020. In the current contract, we did make a few changes for the 6-month period. Of course, the contract term transitioned from June 30th to December 31st. We removed references to the Kentucky Health language. Remember, Kentucky Health was the 1115 waiver that required certain Medicaid members to work or volunteer in order to maintain their Medicaid eligibility. It also eliminated vision and dental benefits for adults. The medical loss ratio adjustment period has been extended to the extension. One change that we heard from providers was that the timely filing period for Medicaid managed care organizations was different from our fee-for-service, which is 365 days or a year. So we have made a change in the current contract to allow providers the same 365-day timely filing period as we have in the fee-for-service population. If you can't see my slides, I'm going to go ahead and skip over some because I have some that depict the average Medicaid enrollment and expenditures. We spent, in 2019, we spent roughly $7.5 billion in our Medicaid managed care organizations, and we spent roughly $3 million in our fee-for-service population. Now that equates to about 70% of our population being in managed care, which is again 7.4 million. So about roughly 10% of our population, which is in fee-for-service, accounted for almost 30% of the Medicaid cost in 2019. Our average member per month has remained steady with our managed care organizations. In 2019, the average fee it was roughly under $500, and compared to the individuals who are enrolled in fee-for-service, the per member per month was over $2,000. So some key contract enhancements and programmatic changes that we made to the 2021 contract. The timeline, of course, we released our RFP January 10th, 2020. Proposals were received on February 7th. We then experienced the COVID state of emergency, but trying to get back to business as usual, we did issue contracts May 28th. Those contracts were issued to Aetna, Humana, Molina, United, and WellCare. Those were awarded May 29th. We have a current anticipated start date of January 1st, 2021. The significant changes in the 2021 MCO contract, we have one MCO supporting Kentucky youth serving our foster children. It's called SKY, supporting Kentucky youth. So one MCO will be delivering care for children enrolled in foster care and those who are dually committed. Again, we removed references to Kentucky Health. The contract term has been changed because originally we anticipated those contracts were set to start July the 1st of this year, but you are aware of the reprocurement process that happened. So that has pushed out the start date to January 1st, 2021. The contract does require or does include 4 additional 2-year renewal periods and optional renewal periods. Pharmacy language has been amended and beefed up a little bit. We've added references to the Kentucky statute specific to Senate Bill 5 to require MCOs to comply with all requirements in that Senate bill. We have changed language to ensure that the state can claim and maximize rebates on physician-administered drugs. We've revised the cycle in which drugs are reviewed for a preferred drug list from 3 years to annually. We have removed the MCO PBM ability to charge hidden fees. We have a single pharmacy drug list, and we require pass-through pricing, requires that the pass-through pricing versus spread pricing, which creates more transparency with regard to the pharmacy benefit manager. And we will have to modify the 2021 contract in the future based on requirements for Senate Bill 50 and the single PBM for all MCOs. We've also inserted language so that the department can have more input or more leverage with subcontractors. We can deny or approve any subcontractor. All subcontractors must have appropriate training and education, and the MCOs must share their third-party liability information with their subcontractors. We've also increased quality expectations. We expect the MCOs to support Kentucky goals in transforming the Medicaid program. We have expanded requirements for ongoing monitoring of performance and addressing outcomes to identify needs for adjustments. We've changed the utilization management criteria so that it's transparent. We've amended specifics for telehealth based on KRS 205.5591. And we also have inserted that medical necessity criteria must be based on scientific evidence. We don't want the MCOs coming to us with homegrown criteria, for example, to develop prior authorization. It has to be something that is actually validated. It's related to provider services. We have inserted a requirement to be consistent with KRS 205.532 for one credentialing verification organization. We've added topics to education requirements for providers, updated information related to the provider network to comply with KRS 304.17a-515. We've also inserted language stating that the MCOs cannot automatically enroll providers in any other product offered by the MCO. As far as termination of providers, we expect them to give us an exit survey when a provider is terminated. We want to know why they were terminated, and they have to give notice to the department. In addition, they also have to notify the enrollees, and that has to coincide with timing of the provider termination. We don't want a member out there who, for example, may have a primary care provider who was terminated and they don't know until it's time for them to have to schedule an appointment. So they have to give notice to their members. Case management, we've revised the contract to include a population health management program to hold the MCOs accountable for addressing care needs. So for example, we don't want to just again, it's going back to Medicaid's role in the delivery of healthcare. We don't want to just pay for services. We want to pay for improvements in services. So we want to hold them accountable to addressing the healthcare needs. We want to make sure our members get the appropriate care that they require. We also have specific conditions and populations for priority based on the highest needs in the Commonwealth. For example, we know that diabetes, heart disease, asthma, those are some of the highest needs in the Commonwealth. We want to make sure that they have plans of care to address those issues and make sure individuals are receiving treatment for the conditions that they have. As far as reporting, we want the NCOs to participate with the department and develop a package of reports that is consistent across MCOs. So we want comparable data. We want to be able to compare apples to apples with our MCOs. We know that Medicaid data is very complex sometimes, and the way that you pull and report data, while it may look the same on paper, what went behind those reports to pull that data into that report may have some slight difference that skews one or the other. So we want to make sure it's all consistent. And we did insert some telehealth reporting requirements. We beefed up our remedies for violation, breach, or non-performance of the contract. We expanded language to define the department's right and decisions in addition to the MCO responsibilities. And we have inserted language stating the MCOs must maintain a $30 million performance bond throughout the life of the contract. A few payment strategies that we have inserted into the new contracts. We describe the department's risk adjustment model and indicate that supplemental pass-through payments and payments related to the health insurance premium fee will not be risk adjusted. We've indicated that the department may, at its discretion and subject to CMS approval, implement medical loss ratio incentive programs by which the MCO may reduce its allowable MLR. But again, this is so that we can make sure that our members are receiving services, and we want to see results. We've also added language to allow the department to develop and require the MCO to participate in a value-based payment model. And I think with that, will end my presentation. I'm sorry that you couldn't see the slides. I'll be more than happy to forward them to you. I think they are online. And if I could open it up to discussion and see if you have any questions for me.
Yes, I just want to encourage the committee members to follow your presentation. It was sent out with the email this morning, and you've done an excellent job with this. Again, a wealth of information, greatly appreciated. And I'm thinking that possibly we need to have a follow-up on this as well, because there's so much information that you've given us today, and appreciate that the work you're doing. So if we could invite you back to a future meeting, I would appreciate that opportunity. Get a lot of questions, and let me start with Senator Alvarado.
Thank you. So, Commissioner, thanks. Actually, pleased to see a lot of the things you put in this, and I'm looking at your PowerPoint here, and a lot of the things that were incorporated in these contracts. And I guess not so much a question, but just an urgency. I mean, I think for the last 10, 11 years now, there's been a lot of, everybody's heard the frustration, particularly from this committee and welfare regarding a lot of these MCO contracts. And I would just like to urge you again, as these contracts come through, is to really hold these companies, their feet to the fire effectively, because I think we're starting getting to the point, we've seen it. We're filing a lot of bills and legislation to require the people that we're contracting with to follow the contracts, which doesn't make any sense. And so instead of filing more legislation to bring these folks in line, is to start enforcing a lot of the things that are in these contracts. I'm encouraged by a lot of it. I like obviously that last slide. You're looking at value-based payment models is to put innovative things like accountable care organizations together, which I think might be able to work well with Medicaid. It incentivizes providers. And a lot of the credentialing issues, the bills that we've passed, obviously, as a General Assembly in the past that you're looking to put into this. So I'm encouraged by seeing a lot of the things that are here. I would just encourage you to really be a stickler in enforcing these, because if they're not enforced, you're gonna hear from us, obviously, in this committee. And I think we've even told the new players that are in the market, like Molina, United Healthcare, it's an opportunity for them to I think establish a good relationship with providers in the state, and the ones that have already been here that I think have done quite a few improvements to try to improve their reputations. I've encouraged them also to say, just consider this a reset and to start moving forward in a positive way. But really encouraged by a lot of the things that are in here. And like I said, just urge you to really hold these folks, if they don't play well with the state, to not be frightened to say, to threaten them and remove them as a participating agency in Kentucky. So that was all, just a comment more than a question. Thank you, Mr. Chairman.
Thank you. Representative Prunty, you have a question?
Yes, and a few comments. Thank you, Mr. Chairman. I want to echo Senator Alvarado's appreciation for actually implementing pieces of legislation such as the single portal for providers. I've heard about that for credentialing for years, that you have to do different credentialing in every different company, every different MCO, implementing the PBM legislation. I just appreciate that. I just wanted to comment about the 1115 waiver. I believe it eliminated vision and dental, but there were ways for people to earn that. And as someone who worked home health physical therapy for 10 years, I don't think asking people to work, volunteer, go to school, if they weren't taking care of an elderly frail parent or a disabled child, 20 hours a week was not too much to ask. I believe that was a path to self-sufficiency, and I would love to see that continue to be looked at. My question is, what kind of caught my attention, and I think I understood it after it went past me, but I just want to clarify. When you said 70% of the population and 30% of the population, you're talking about 70% of the population of your Medicaid population, correct? And 30%.
The Medicaid population, out of all the population, 90% is assigned to managed care organizations, and 10% is in fee-for-service, the long-term care, and the home and community-based waiver programs. So 10% of our population accounts for almost 30% of the cost in Medicaid, and the 90% accounts for about 70%.
Okay. But out of curiosity, what is the percentage of our total population in Kentucky that is actually on Medicaid? Do you know that off the top of your head, or is that?
Yeah, that's something I look at on a daily basis. And currently, 1.4, almost 1.5 million of the population in Kentucky is enrolled in Medicaid out of a 4.4 million population.
Okay, thank you very much. Thank you, Mr. Chairman.
Thank you. Representative Sheldon, you have a question?
Yes, sir. Thank you, Chairman. And Commissioner Lee, what a great job. I appreciate knowing you're quite versed, and it sure helps us moving forward. A couple real quick questions. You were able to award the MCO contracts, obviously without, I guess, them knowing what PBM they're going to be working with. Can you give us a timetable on if the RFP have gone out for the PBM? And if so, when you expect them back, and when do you plan to announce the single PBM that will be working with our 5 MCOs?
Currently, we anticipate the PBM RFP hitting the streets within the next few months, I believe. But our goal is to have the PBM, the single PBM, on board by January 1st, 2021, which I believe was outlined in Senate Bill 50. So our goal is to have it online 1/1/21.
Yes, ma'am. I just would. Thank you very much. I know that there's going to be a lot of discussion, on what single PBM, you'll use. I just want to. We put in Senate Bill 50 some language. Could have been a little stronger, I think, but we did what we needed to do. But we were very concerned about using a single PBM that had any type of relationship with any of the MCOs, any kind of common ownership, that kind of thing. And I believe if you look, we didn't mandate it, but we sure strongly encourage that we try to find a single PBM that had no business relationship, so that we didn't have that out there. So I just wanted to mention that. Another question, if you will, Chairman, on the single PDL list, Commissioner Lee, I suspect that single PDL list is going to really help us when it comes to supplemental rebate. I know we're a member of a interstate compact of 13, 14 states where we've not been able to really contribute to that as much as we're going to this time around. I want to think it's 300,000 or 400,000 is probably going to move up to close to what 1.4 million. Have you done any projections or anticipations on how much money that's going to mean in supplemental rebates coming back to our Medicaid program?
Yeah, I have not personally done any of that. I'm sure that our pharmacy director has done that, and he will have some of that information.
Okay, and then lastly, and I'm sorry to hit you up with these questions. I know you must feel like the weight of the world on you, and we're sorry to be pounding on this, but I just want to put your predecessor, we ran into an issue, and I just want to bring it to your attention so that you can be watching for it. You probably will anyway, but it was, I want to think it was a year before you got there, maybe 2 years before, where the MLR was kind of, I don't know what word to use, but was I would say monkeyed around with by the MCO. Bottom line is that they moved services money that should have been in services over to the admin side. That was picked up by our Medicaid commissioner at that present time, and they had to pay $7-8 million back to the state of Kentucky when that happened. So that kind of follows up on Senator Alvarado's comments about we have really got to watch that kind of thing. And I was sitting in the room when we asked, can we go back to previous years, because they've been doing it a number of years, and the contracts didn't allow us to go back but 1 year. But 1 year got $8 million back for Kentucky. So I just want you just going to throw that out. Not that anybody else would ever try that again. I'd like to think not, but just to be on your radar there, watch that, because I know, like you said, it's something you watch all the time. So thank you for your work, and that was, and I do want to encourage you to try to go with a more transparent pass-through PBM that has no relationship. Thank you very much.
I want the committee members to know that we're trying to hold these meetings to an hour and 30 minutes, and we're an hour and 15. So you've done a commendable job. And I think Commissioner Lee, you got a lot of credit for that because you've come so well prepared. I have one final question, but before we get into that, I would like you to talk a little bit about the transition to the new MCOs. We have one particular, we got 300,000 people that'll be moving to a new one. And how are we assuring that we're not creating a bureaucratic nightmare for healthcare providers? The same token, assuring that these 300,000 people will have adequate coverage when the time comes.
Well, the current contract does have a very detailed outline of how individuals will be transferred, but I believe a lot of this will be contingent up on the outcome of the protest, and probably not something I can really talk about right now because don't know, but the contract does have a very specific detailed outline. I'd be more than happy to just pull that piece out of that contract and send it to you by email, Senator Meredith. And
Thank you. I appreciate that. Great.
You could share it with the committee.
Thank you. Representative Prunty, you have the final question.
Oh, well, thank you, Mr. Chair. Sorry I didn't get this in the first time. Commissioner, in your presentation on the 2021 MCO contract under quality, you said you expect the MCO to support Kentuckian goals to transform Medicaid program. Can you just expand on to what your goal is for transforming the Medicaid program, just succinctly?
Well, I think that Medicaid, if you look at what Medicaid does and how big we are, Medicaid currently covers almost 1.5 million people. We have 56,000 providers. We have a $12 billion budget. Medicaid needs to be more of a payer of services. We want to see results. We want to identify populations that need help, and we want to see improvements. We need to get a baseline set of information on how our health status is today. We know that Kentucky is usually right at the bottom of everything. We want to start elevating our health status, and this goes back to what this committee is saying, and that's holding these managed care companies accountable. We want to establish some baseline information on what their membership looks like, and we want to see some improvements for the money that we're paying. And if we don't see improvements, we want to know why. Is it because all the other states are improving at the same rate we are? But our goal, and I think I may have told you guys this, I believe that the Medicaid program was created for the Medicaid member. We have a responsibility to assist those individuals who are very vulnerable. They have Some of them have they have comorbidities. Their healthcare status is not as great as some of the other populations. We want to increase their health status. We want to help elevate them, make sure that they're receiving their medications, that they're adhering to their medication regime. We want to just elevate that status. So that's what we talk about when we talk about transforming the Medicaid program. We want to be more of a player in improving the health status. We want to move away from being a payer of services to being a driver of healthcare policy that improves the healthcare status of this state.
Thank you very much for that explanation. And I greatly applaud that. And I hear the word accountability for MCOs, but I think we also have to build in accountability for patients when they're able. You know what I'm saying? So Foundation for a Healthy Kentucky, I think, has those same goals, and maybe we can all collaborate together to make that happen. Thank you for that explanation, and thank you, Mr. Chairman.
Commissioner Lee, I appreciate your philosophy behind this and certainly embrace it. And I'm sure most of these committee members do as well. I've said since I came to the Senate in 2017 that I think the Medicaid budget is as large as it ever should be, because if we're working on getting people back into gainful employment where they get health insurance to their employer, and we really focus on improving the health, we can reduce this budget. And I think focusing on the Medicaid recipient is certainly the right approach. One of the things that concerns me, though, is access to care. It doesn't matter if you have healthcare coverage if you don't have healthcare providers to provide that service. And we've talked ad nauseum today about the impact on rural healthcare and how fragile the system is. So that's something I hope we continue to have further dialogue on, because it's something very near and dear to most of us. And just like you, we want the best for the Medicaid recipient. And, you know, $1.5 million or 1.5 million people is not a number that should be a source of pride for Kentucky. Again, that one is as big as it ever should be. We need to work very hard to build the economy of this state, to get people in the gainful employment and reduce that number. And I think that's a measure of success for us, is reducing the Medicaid recipients through gainful employment and improving the health of our population. If we have not done that, then we've not been successful, any of us. But appreciate you being here today. And I know you put a lot of time and effort into the presentations. That's evident. And again, I'd ask committee members to make sure you look at these slide presentations that were put together. And we certainly would like to have you back at a future meeting to talk in more detail about some of these. But you've done an excellent job today, and you certainly have our full support. With that, I would ask if there are any committee members who we have not accounted for so far. We want to make sure that if you came in late, that we have you recorded in the minutes as attending. So did anyone miss the roll call earlier? Hearing none, then I'll advise you that our next scheduled meeting is July 29th. And we'll certainly send out the agenda 2 weeks beforehand. But if there's no other business, appreciate everyone's participation today, and particularly you, Commissioner Lee, and wish you the best going forward. And anytime we can be of assistance, please don't hesitate to call upon us.
Likewise, and thank you for having me. Look forward to the next meeting.
Thank you. And with that, committee members, we are adjourned. Thank you.